So now let's talk about assessment of high-risk pregnancy. So in the past, we only considered high-risk factors to be like medical, obstetric, physiologic categories. But now we have some newer, some broader categories. So we're looking at, yet again, biophysical. So the genetic background of a pregnant mother, her nutrition, her medical history, her obstetric history, all of that falls under biophysical. Psychosocial, smoking, alcohol, drug use, are these going to play an impact on the pregnancy and the health of the fetus? Definitely. So we're going to look at those risk factors as well. Sociodemographic. So what is her income? Does she have health insurance? Does she make just enough money to not qualify for medical assistance, but her healthcare premiums are so high that she's carrying, or a very low plan, that sort of thing. That all if you're paying for 50% of your prenatal visit out of pocket, are you going to want to go to every single visit week after week after week? Absolutely not. You're going to try to space those out. And when you're concerned about a high-risk pregnancy, can that have an implication on the delivering process and whether or not we have a healthy baby? Absolutely. What is her age? Is she 14 years old? Does she not understand really what's happening? Is she 38? And this is a huge shock because she has a 17 and a 16-year-old, and now we're having a baby. Parity. How many times has she been pregnant? How many times has she been pregnant and had a successful delivery at term? How many losses have we had? What about her access to care? Does she have transportation? Is it feasible for her to be able to get to her prenatal visits? Environmental. So again, let's look at, the ChemTool plant. Currently it's, 2021, and we had that huge fire up in Roscoe-Rockton area with the ChemTool plant. Are we concerned about water? Are we concerned about teratogens? Cancer-causing things like lead and mercury. Does she work someplace where she is dealing with those chemicals? So again, all of those are risk factors that we take into account. We start assessing that risk during the initial intake visit, so usually between 8 to 12 weeks of pregnancy. We also begin testing additional some specific issues we tested a lot earlier than this, but for pretty much everybody, testing is usually done by 32 to 34 weeks and continues until delivery. So it's one of the things that we do, really low risk intervention, is a daily fetal movement count, aka the kick count. So this is, usually like the presence of fetal movement is generally a reassuring sign of fetal health. So things that we're concerned about as far as oxygenation, pregnancies, this is very, very important if we're concerned about perfusion at all. There are several different protocols that can be used for counting, but essentially the idea that we have fewer than 3 kicks in an hour warrants further evaluation by a non-stress test. So these body movements, just FYI, you should be feeling around 30. The pregnant mom should feel about 30 of those per hour, even through that 3rd trimester. They do not necessarily decrease in number closer to term, but perhaps the mother doesn't feel them as much because they are smaller movements because the fetus is hindered by the size of the uterus. So when we talk about a non-stress test, one of the first things that's actually, so your book talks about count fewer than 3 warrants further evaluation. You call into your provider's office and you say, hey, I haven't felt my baby move like it's supposed to. Some of the things that they're going to tell you to do include lying down, resting, really thinking about those fetal movements. really focusing on that, giving that all your attention. They will encourage you to drink something cold. The idea that we place something cold in the stomach, kind of close to that amniotic sac, the baby feels the temperature change and gets a little bit of a shock. So, and then usually sometimes too they recommend like orange juice or something high with a sugar content as well to get that baby moving and grooving. Some of the testing that we do includes ultrasound. There are different types of ultrasound that are done. There's abdominal and a transvaginal. Now, the transvaginal is used more commonly in that first trimester when essentially the fetus is so small that it's very hard to pick up using an abdominal ultrasound. After that first trimester, we're able to move to the more comfortable, less invasive abdominal ultrasound. Trust me, most of us would prefer an abdominal ultrasound versus a transvaginal. Just FYI, they will usually tell you to come to your appointment with a full bladder because it pushes that full bladder pushes that uterus up, and that uterus then it's easier to see the fetus inside that uterus. Now, in this particular figure, I think this is a very interesting figure that they're using, because on this one you see the pubic symphysis is kind of up on the right upper portion of of that figure, and then you see the full bladder kind of right next to that, and then the placenta. So obviously this placenta has adhered to the front of the mother's abdomen. So when you have a fetus with an anterior placed placenta like this, it's going to be more difficult to feel that fetus kicking and moving, because usually people want to see those exterior movements of the fetus, like you can actually see the baby moving around inside the woman's stomach and doing those little elbow shots and those knee shots, and you're going to not feel those as soon or as early on when you had that anteriorly placed placenta. So that was just an FYI. But some indications. So why do we do the ultrasound? Why do we care about it? Well, there's more to it than just determining whether you're having a boy or a girl. And, so many genetic tests now that we're doing early on determine that or provide that information without the use of ultrasound. But we're going to be looking at that heart. So we can see on a transvaginal or ultrasound as early as 6 weeks, we can see that fetal heartbeat. On an abdominal ultrasound, we can be looking at that at 13 weeks. Gestational age, we look at this crown to rump length. So looking at like that head circumference is another way. Biparietal diameter after 12 weeks. The femur length after 12 weeks. So we can get an abdominal circumference, we can get a head circumference to kind of help us with determining what is a gestational age, especially in a woman whose cycle has been really irregular. If we're concerned about fetal growth, if we're concerned that this baby is not growing the way that it should, we know that reduced fetal growth is often associated with stillbirth deliveries. So we're going to be wanting to keep a very, very close eye on that baby, especially if mom also has a history of stillbirth deliveries. Some other concerns would be like a poor maternal weight gain, if she's had a previous IUGR, which we'll talk about later, if she admits to drug use, if we've got diabetes already rolling, if this is a multi-fetal pregnancy as well, we're going to be keeping a close eye on whether or not that baby's growing. And then otherwise, we also look at fetal anatomy. So is it normal, or are we seeing some malformations which would require the use of additional specialized ultrasound? So when we're talking about the concern for physical anomalies, so if we see something abnormal on that that anatomy ultrasound, we're going to be concerned about fetal genetic disorders. So then we use ultrasound to help us figure things out a little bit more. So nuchal translucency is looking at the measurement of the fluid in the nape of the neck. Okay. before the spine completely closes between 10 to 14 weeks of gestation. Anything greater than 3 millimeters is going to be considered abnormal. And then if we take that nuchal translucency along with any kind of other markers that are red flagging us, we could be looking at some chromosomal abnormalities for that fetus. Placental position and function, as I just mentioned with that last picture that we were looking at, it helps us to determine where the placenta is at. This one is anterior. If we have a placenta that is low-lying, then we're going to be concerned that during that cervical dilation process, if that placenta is lying directly over that cervix, well, then we start to lose some of that perfusion to our fetus, and that could be a very dangerous situation. We also look at placental grading. So things like calcium deposits within a placenta kind of give us an idea that that placenta is aging out. Now, the placenta will not work forever. At about 40 to 42 weeks of gestation, that placenta starts to deposit calcium and fibrin. And that if we continue to say, okay, I see some calcium deposits on your placenta using the ultrasound, but I'm just going to let it go. We could have some hemorrhagic infarcts from poor perfusion to the fetus. So again, that's not a good idea. These calcium and fibrin deposits, if we note them on a routine ultrasound, it also gives us an idea that we may have some difficulty removing that placenta following expulsion of the fetus, and so the provider might be more prepared to go in and do a manual removal of the placenta. Some other tests that we do, as I mentioned, would be that nuchal translucency and then the Doppler flow analysis. So when you're lying there as a pregnant mom and they are doing the ultrasound, you see them do this Doppler flow analysis, so it shows up as blue and red on the ultrasound, and it's showing really that diastolic and systolic flow rates, the resistance. They're basically looking at estimation of blood flow into various arteries. Most frequently, they're very concerned about the umbilical arteries as well as the cerebral arteries, as those are going to play a very important role in the health of the fetus. It's looking at fetal adaptation, it's looking at fetal reserve, and then it's also used when we're trying to determine whether this baby is IUGR, so that intrauterine growth restriction, if that baby is just smaller, or if the baby is actually compromised. So let's do a Doppler blood flow analysis. Is the baby small but thriving, or is the baby small and compromised? We're also going to measure amniotic fluid volume. This is really important. Amniotic fluid volume, you're going to hear more about this as we continue to move forward. Amniotic fluid volume that is measured to be abnormal is frequently associated with fetal disorders. The total AFV measures pockets of fluid in all 4 quadrants. So if, for example, we have oligohydramnios, we're going to have a measurement of less than 5 centimeters. A low to a normal is between 5 to 10 centimeters. Normal is greater than or equal to 10 centimeters to 25, and polyhydramnios is greater than 25 centimeters. If we have polyhydramnios, again, like I said, we're definitely concerned about fetal disorders. Why do we have that polyhydramnios? And then we'll also do a biophysical profile.